Welcome to the Spirit of a Badass, where we celebrate stories of courage, hope, and resiliency. I am your host, Alecia Jacobson. Hello, hello, hello. Welcome to today's episode. I think I have like the ultimate badass with us today. Before we get in, I just got distracted a little bit. I have the Nuuly that I talk about all the time. I have this tank top on. I'm already sweating. I feel it. So whenever I talk about women's health, and you all know this, I start sweating profusely. And I rented this like tank top sweatery thing, a holy cleavage. So I'm going to be like adjusting it the entire time so that the clips that we take, I don't have to like put a little emoji on. I'm not used to cleavage, and it's totally just like I'm trying to get the microphone in front of it so like you can't see it. So that's where I'm at today. So hopefully I can stay like on point and not get distracted by like my sweating and cleavage that's happening here. And also the Nuuly, like I absolutely love it, but I was not prepared with like a little tank top underneath it, you know, like circa like 2010 that we all had. I no longer have the like base layer. It is just the outer layer. And there is a lot happening on the front side here. So let's get into this because my guest today, first of all, one of my clients shared her name with me, and I looked her up immediately because, you know, with my clients, what are we talking about? Women's health, perimenopause, stress, weight, like all of the things. And I get so frustrated with this. And anyway, I was with a client and she's like, have you heard of Miranda Zuhlke? And I said, no. And she's like, yeah, she's doing all these things. And so I immediately looked her up and I'm like, I need to interview you. So today's guest is Miranda Zuhlke, a powerhouse physician's assistant, doctor of medical science candidate, and certified menopause provider through the Menopause Society. She also is an ASEC certified sexual health counselor who helps women reclaim their pleasure, confidence, and power in midlife. Miranda is the founder of Midlife Rising, a movement dedicated to helping women rise into their most vibrant, unapologetic selves. Through her work, she's breaking the silence around menopause, rewriting the narrative on aging, and reminding every woman that midlife isn't the end, it's the awakening. Welcome, Miranda.
Thank you. Thank you so much for having me.
Like, seriously, I am so excited because, well, every woman listening to this knows why I am so excited, because we feel that there are no answers. And I feel when I'm sending women places, it's like, I'm like, oh, here's a book. Here's a podcast. It's like a combination of a treasure hunt with a broken map and like pin the tail on the donkey with your eyes freaking blindfolded. And it's like, what the hell are we supposed to do? And we have a few of you experts out there who are now rising up and saying, I can help you. And whenever I find one of you out there in the wild, I'm like, come to me, because it is so frustrating. And this isn't what you set out to do. Your life's path brought you here. So if we can rewind and tell us about, you know, who you are. And I mean, powerhouse, I think is an understatement, because you are out there like doing hard shit and advocating, and you're just the passion that just reading your website, the passion that you can feel it. It's like you are one of those people that it like oozes out of everything that you do, and you're not afraid to go to the hard places, which I absolutely love. So tell us how did you get to where you are today?
Oh, you're so kind. Thank you so much for that. Yeah, I did not set out to do this. I grew up rural, small town, Wisconsin, about an hour southwest of Madison. And when I look back and reflect, my path really did lead me here, although I had no idea. So I always wanted to be in medicine. When I grew up, I thought of like Dr. Quinn, medicine woman meets ER, you know, the old school ER that's now making a comeback with the pit. And that's kind of like what I went after and who I wanted to be. And I got there eventually and worked for my first 7 years as a physician assistant in the ER. And during that time, you know, time doesn't wait for anyone. It just happens and it goes by. And I constantly saw women get dismissed. And in that, I was going through my own infertility journey and went through multiple double-digit rounds of IVF. And that has by far been the hardest thing in my journey, is building my family and just the choices that you have to make with that I never thought I would have to make. I luckily came out on the other side, and I have 2 children thanks to IVF, but there was one consistent thing in all of this, and it was women showing up for women. And I had to have 2 gestational carriers carry my children, and my youngest turns a year and 10 days. So it's still all really fresh for me. But once I got to the other side, I really had a reevaluation of, what the fuck am I doing with my life? Like, this can't be as good as it gets. And it was great. I had built my family, and I have an incredible partner, and my career was good. But in the ER, I was doing all these badass things, or so I thought, but I was like, what are we really doing? And my first love was emergency medicine, but there was also this pull to something more. And I think part of my journey with infertility really showed the gap in women's health. And then as I aged, because it took 10 years for me to build my family, I really saw the impact of perimenopause and menopause. And I just thought I belong in that space. So I made the hard decision to leave my life and chapter of the ER and then move into women's health. And that's where I am now. And I look back and I'm like, I couldn't have planned it better, but here we are. And now I'm just find my passion in really educating women during this phase, because we get nothing. We don't get it in PA school, medical school, NP school. And then it's like that preparation. You're at the height of your life in career, partner, everything. And then perimenopause and menopause happens. And we're like, what the fuck? And nobody knows how to guide you. So then I set out to educate myself on sexual health and menopause. And that's kind of how I landed.
That is incredible. And I feel like that's how every truly remarkable change maker gets to where they are, by finding this shit does not work. The system is broken. And how can I be a part of the remedy?
Yeah. Yeah. There was just nowhere. And as I looked for mentorship, there wasn't any. And I was like, do I need to fly to Europe and study in Amsterdam to figure this out? Like, I just have no idea. And it was this was all before menopause kind of became cool. Like right now, perimenopause is having a moment, but it was my curiosity and commitment that really made me move in this direction. And I'm just happy everyone's talking about it. And my goal is that you get women to the information they need to make an educated decision and not get fooled also by a lot of marketing out there. So,
ooh, okay, let's go there. Because what is that marketing, and what are the things that we should be looking out for? Because sometimes it gets, I mean, if you think 10, 15 years ago in even like the health space, we were completely getting bamboozled all throughout. It's like, eat this, don't eat this, do this, do that, So what are those things as you see it to be kind of eyes open to?
Yeah, and I see it every day. So I started Midlife Rising as this educational platform for women. And at my full-time job, Tuesday through Friday, I work in corporate wellness at an incredible local biotech company that saw the power and the importance of having menopause care for women. And when women would come to me, and, we live in a great Madison area with a lot of great educators and physicians and practitioners. But by the time women would get to me, they would have a whole list of supplements, from magnesium to black cohosh to supplements that I've never even heard of. And they've spent hundreds of dollars on them. And I'm like, did anyone tell you about hormones or talk about localized vaginal estrogen? No, we're just doing all these other things and spending all this money. So I really just spend a lot of my time now educating on that. And there are, supplements aren't FDA regulated, and you can basically put anything up and sell it online and claim anything. So it's really, really, really hard to weed through that. But I also understand how it happens. You're doom scrolling at 2 a.m. because you can't sleep, because you're woken up from your hot flashes or your insomnia or your worsening anxiety. And then you're like, oh, this is what I need. Add to cart, add to cart. So I get it. And some of them may be helpful, but it's hard to weed out what is and isn't, because it's even hard for me sometimes.
Yeah.
But education is power. So I just keep trying to educate. This is what could work. This is what couldn't, and go from there. But a lot of it can be fixed with hormones and not some supplement that you're going to pay $300 a bottle for each night, or the creatine that's marketed by XYZ.
Yes. And it is so hard. And a lot of the women I work with are like, well, I tried this, and now I'm taking everything out, or I'm going to add this in, because there's the list of resources that I have for the women I work with, it's like, okay, try this place. This place can do labs. This place can do this. And there's not centralized and anything. And it's so infuriating that it just can't be this cut and dry. Here is the information where you can go find it, that it is that doom scrolling, or, oh, I found this influencer and they said that this and this works, so I'm going to try that for a month and see what happens. That whole, and I love the idea of trying things and seeing, I have very clearly say that I will use myself as a little bit of a guinea. I just try shit and see, how does this make me feel? But also I'm doing it with a certain amount of awareness of the expectations. And so there's just a lot of shit that people are throwing in themselves. And yes, the amount of money, I have an old lady pill box that I get from my acupuncturist. Now, I do feel better when I take them. However, I have so many people that are like, well, I don't really know. And they're fucking expensive. They are so expensive.
Yes. And I went through that myself with infertility, right? There was all this, books I could read, influencers in that space being like, take this, it'll help with egg quality. This will help with your LH surge. This will help with this. And it all came down to hormones. Meanwhile, I was giving myself massive amounts of hormones, much around 2. Nobody ever said to me when I went through infertility, you're taking this estrogen and progesterone, it might cause breast cancer, stroke, blood clot, anything like that. But yet we tell the perimenopausal and menopausal woman that before we prescribe. So that too is just another parallel of why is it okay then and not now? And in the misinformation and the lack of staying up to date and clinical education to prepare you for this chapter. It's no wonder. I don't know how any woman could easily navigate this without a perimenopausal, menopausal course.
Yeah,
there's just no way.
I've said so many times, if I do not have a medical brain at all, none of it, it doesn't stick, but I'm really good at collecting resources and giving them for people. To have a you out there is just makes me so happy. So the women I work with, questions are, why am I gaining this weight when I was able to keep it off? 100%, now this is perimenopause, not menopause, but I had 2 life events where it was all of a sudden 10 pounds, over a freaking night. And I have the answers of nutrition and health. I was doing checking the damn boxes, and I'm like, what the hell has happened here? So that is one that I have people saying the sharpness, the lack of mental clarity, the brain fog is a common thing. The sweating. I have a friend, her feet sweat, and she's like, this is so weird. And she kind of started hormones and then went off because she went with a different practitioner. And there's all of this, it feels like the teeter totter. So if somebody comes to you, you are the expert, you are the educator. What the fuck do we do?
Yes. So great question. We could do a podcast just on this. And actually, that's one of my things coming up is how to get your provider to listen, how to go to your provider with the things that will help you. And let me back up with, hopefully in 10 years, primary care will do this. OB-GYN will do this, and I don't blame them for not knowing. Primary care has an impossible job. They're the glue that holds everyone together. They are brilliant. They don't have time to do a perimenopause or menopausal consult. And then who's going to pay for that? But we need them to, because I can't see all the women in Wisconsin, Illinois, and Iowa as much as I want to. I know. And I thought that was the answer. I was like, come to me. I will take care of you all. But then that's how I shifted into this. I was like, my only goal through all of this is how can I reach the max amount of women to educate them, because knowledge is power. And also, as we get into midlife, we are so fucking badass in who we are and everything we've been through. And I get choked up thinking about it, because every woman has their story and we have survived all the shit to get here. And the reason why the patriarchy is afraid of us is because by now, if we felt good and didn't have that brain fog, that weight gain, mood swings, we actually slept, we would be unfucking stoppable. And we are. And now this is just your launching pad.
Can you imagine? Can you imagine?
I know.
I truly can't even. You're 100% spot on, because I see what we all do feeling like shit 80% of the time. The stories I hear and the things and the work that women do, just my small pool of my little corner, is remarkable. And we all feel like shit the majority of the time.
I know. It's just, it is truly incredible. And it's not like, I have a male partner. He is phenomenal, but he cannot do what I do. And he shares the majority of the mental load. We split domestic household tasks. We are raising boys, and these little boys are the most feminist little things out there, because they see the value in how everything functions when you have a strong, happy, healthy, fully slept mother. And my husband would gladly walk beside me or let me walk in front and say that loudly. Sometimes men are real intimidated when they meet me and hear this, but the ones that are smart and views relationships as equal, they know that you're just stronger together. I mean, they could not, my husband's like, there's no way I could deal with that. There's no way I could deal with bleeding, with infertility, with menopause. And that's the truth. They just couldn't. I mean, they can't. So sorry for that little rant, but back
that's
to
right. I'm wearing the tank top for the rant.
Yes, it's essential. It's so essential. So I think in 10 years or so, hopefully we'll get there. But when women come to see me, and this is the hard part, perimenopause is the hard part. Menopause is the easy part. That's 1 year, no period. Yeah. I mean, and that's the majority of my practice too. And I have a large practice, and this is consistently what I see. Menopause, 1 year with no period on the calendar. You can move to, and this is a broad treatment regimen, but you can usually replace estrogen and progesterone and maybe a little bit of testosterone, and they do relatively well. The perimenopausal space is what's hard, because at really your late 30s, mid to late 30s, your estrogen and progesterone start declining, and it won't be like this smooth sailing. You won't get the memo. You will just think you're losing your mind. And that's what I see. And everything looks different for every woman. I'm a twin, and my twin and I are in different stages of this.
Oh, that's so interesting.
It's wild. It's so wild. And the perimenopausal space, we have in this textbook, we have the straw stages. And ironically, I have it tagged. This is why it's complicated. This is the stages of reproductive aging. And that's what's happening when we go through, we're premenopausal, we're in our reproductive era, making the babies, trying to make the babies, doing everything to not make the babies if we choose not to. And then we get to the perimenopausal stage, which can last 1 to 10 years. And that's that stage where everything slowly declines. We start to get all of these symptoms throughout our body because we have estrogen receptors everywhere. But we don't just have estrogen, we have progesterone. And then we also have testosterone.
Can you talk a little about what the fuck is happening that we cannot see, however, makes us feel like we're losing our minds?
Yeah. So, very simplistically put, our cycle, really anywhere from 28 to 35 days is a normal menstrual cycle. Our whole goal during that is to ovulate, kick out an egg that can meet with a sperm and become a baby and implant. So that's all driven by our period and estrogen and progesterone. So we go through that reproductive era where we usually feel pretty good. Then we slowly lose, usually kind of progesterone first. And that will be things like what you may see is maybe an increase in anxiety or mood or ruminating on things at night. And that's very hard to tease out because, again, once we get to this midlife, we are already dealing with immense things in our brain. So then you may not even recognize what's happening. You may just think, oh, I'm a little more bitchy or I'm a little more irritated, but it's all valid, right? You have these environmental things going on that cause that. Your kids are getting older, your parents are getting older, you're having health issues, relationships change. You may also see with the decline in estrogen, and this is wild because really historically we used to think that was hot flashes, night sweats, things that, women come to me and they're like, well, I didn't know this was menopause because I didn't have any of those other things that everyone talked about. But it can be subtle things. It can be like a rash, itchy ears, sweaty feet, change in body odor. So many things. And that's also hard because right now, a lot of people come to me and they're like, I think it's all perimenopause. It is very hard to tease out, but it is all due to the decline in hormones and then the imbalance that we feel in our bodies. It's really tough because women do have testosterone as well, but I don't see a lot of practitioners wanting to test it because they don't know what to do with it. And in medicine, historically too, if you go to your GP or your OB-GYN and you say you want to get your hormones tested, it's really difficult because you're taking blood serum that is just a snapshot in time. It's one day, and your hormones can fluctuate every day, in the morning to the night. So it's really hard because a lot of times what I see is then they come to me and they're like, well, I was told my hormones are normal. But really, the perimenopausal space is a clinical diagnosis that you don't even need labs to treat or change your course of action. You just need an educated provider that knows what to do with those symptoms. So it's tough because in our world, we want a lab, we want validation, but the blood labs are almost always not needed. As you get closer to that last period, you can have, I sometimes may check things like FSH, which will rise as you get closer and closer and closer to that last period. But a lot of times it doesn't change my management, so I don't do it. Because when I replace hormones, it literally is just like salt and pepper that you're adding back in during this time. And it doesn't need a lab. I do like to do it when I replace testosterone because you don't want to get that too high in a woman. It can have some adverse effects. But a lot of times the labs aren't warranted. But what I also frequently hear is women come in with those same weight gain, night sweats, anxiety. I just don't feel like myself. And then you just kind of tease out and it's basic. Nothing that I do is rocket science. It's basic. I just listen to them. I nail down really what is their biggest symptom? What are we dealing with? I make sure that it isn't caused by something else, either thyroid or anemia or some of the other things that we can rule out with other labs by exclusion. And then I really say, what is your goal? Tell me what you hope to feel. What do you hope to get back to? And then we kind of work backwards. The weight gain is real. The brain fog is real. It's all because we get this redistribution of hormones. And in our reproductive era, where we could eat the things that we continue to eat, work out the same way. We used our energy different. And then the brain fog, your body is metabolizing things differently, and you definitely get these symptoms worse and worse as you move through this process. So it is just heartbreaking to me when I get women. I have someone right now who is 38 and her doctor said, you're too young to be in perimenopause. And that's just not true. And there are times when I do some hormone testing. There is a urine metabolite test that I actually trialed on myself. So I really appreciated you saying you try things, because I had to know if it was legit or not. And my N of 1 with myself. And that doesn't correlate exactly to blood serum levels. So it's not perfect. But with her, she was so low on everything, estrogen and progesterone. But I didn't need those labs to make that diagnosis. I just listened to her. And yeah, she will actually be what we call premature ovarian failure. I'm sure she will stop having her period before the age of 40. And that's a huge indication to be on hormone replacement therapy, at least until the average age of menopause, which is 52, because there are so many positive things from having estrogen and progesterone if you have a uterus during that time, that it would be negligent to not have her on that. But her doctor doesn't know. And her doctor also doesn't want to prescribe anything for her because she has a blood clotting factor. But her provider also isn't educated. She can still do transdermal estrogen. So it is a little complicated, but we just need to keep putting the information out there so that women can make the most educated decisions for themselves, and then educate the providers as well.
My brain is buzzing for a hot second here.
I know. I'm sorry. That's so much.
I'm like, which sentence wants to come out first? So you had said you are either working on something or you're doing something with how to talk to providers, which is amazing, because that is one of the things a lot of times. I mean, I have a few spaces that I send women to that I know that they have gotten their hormone replacement and they are listened to, and the providers have the education that is needed in order to fully support them, which that comes at a cost. It is, that is an investment. Now, I have always invested heavily in alternative health, meaning not going to my general practitioner. Now, love them. I am a huge advocate for all medical professionals. And also I have learned through myself and my children that if you don't fucking advocate for yourself, you will kind of be left in the dust. Because, and I have worked with medical professionals also to see the sort of back end of everything that they are dealing with and holding space for. So I realize that they are doing the very best with what they have to do with. And at the same time, our women of the world are being failed when it comes to going in and saying, I need help. So for those going in, could you just give a couple of things to kind of either saying, because I don't know if it's using the right language when going in there, or how can they sort of get from their practitioner what they need, or at least kind of get it moving in the right direction?
Yes. 100%. And, a lot of my friends too, people that I went to school with, they come to me and they're like, oh my God, how do you know this? And I was like, well, I had to do 5 extra years of education going in, number one, with your symptoms, track your symptoms. And really, I became obsessed with this with trying to have my children.
I love obsession. Sorry to interrupt you. I think obsession changes the world.
Yes.
I love a person who is obsessed with something, because it's like you go so deep into that obsession and it's like, oh, this could be this and this and this. And it's so exciting. Yes. Go get obsessed with something.
Yes. And that's the thing too. So when I was going through this, I was in COVID. So it was COVID. I was working in the ER, and then I'm trying to get fucking pregnant, and I could get pregnant. I just couldn't stay pregnant. And I never bought into stress because, when you look at history, people got pregnant in concentration camps. Like my level of stress is nowhere near that. Like stress does do insane things to your body, but this was so incredibly eye-opening for me because I've never went after something and not been able to get it because I worked hard. Like I'm not the smartest, I'm not the best, I'm not the fastest, I'm not the anything. I just could outwork anybody that tried to compete. And this was the thing. I couldn't, no matter how hard I worked, infertility just kept slapping me upside the head. And if I would have listened to my providers, my doctors, and I know as a provider, when I deliver information, I have to be very careful about the delivery and what they hear because they may not hear what I'm saying or they may interpret it differently. And being the patient, I was just like, well, why isn't this working? Why isn't this working? And my providers, they didn't know. Like infertility, we still don't know a lot. I have had 11 miscarriages. I did 10 years of IVF. They still have no idea why I was infertile. Unexplained infertility. I've spent hundreds of thousands of dollars building my family, and that's a privilege, right? Like that is a privilege to even say that. And when I went to my physicians, I got brushed off. I was early 30s and they were like, you just need to relax. You just need to try. You just need to do XYZ. And that's consistently what I hear in my perimenopausal and menopausal women. Like, you're too young. This is too early. This just isn't it. So I would say track your cycle. For sure your cycle, because your cycle, that straw stages that I showed, it is a continuum of our lifespan and how we age and how our ovarian health ages. So track your cycle. And that is hard if you're on like continuous birth control or you've had an ablation or you have an IUD, but you can still track like symptoms. You can track brain fog, mood, all of those things. You can track how you feel. Even if it's just, I tell women, like, keep something by their bed at night. Like, I wake up how many times a night? Vaginal dryness. Does sex hurt? Have you lost like interest in all things? Because so often I do see providers aren't willing to prescribe hormones, but they're willing to prescribe an antidepressant. And women do in this decade, 4th and 5th, 6th decades of life, get prescribed antidepressants much more easily than hormones. But yet we're more than willing to hand out birth control, which has extremely high levels of hormones compared to HRT. So that's a whole other
Holy
thing.
shit, I never even thought about that.
Yes, because in birth control, you want a high enough hormone to suppress those ovaries so they don't spit out an egg and don't get you pregnant. But with HRT, it's just like salt and pepper. You're just adding back what we've lost. We're not trying to suppress the ovaries.
That kind of makes me a little sick to my stomach to think about that. that one is acceptable and one is widely, like, I mean, the amount of times that it's like, oh, birth control. Have you tried birth control? And damn.
Yeah. I mean, and then I do, there is a place for it sometimes.
Absolutely.
Yes. And sometimes perimenopausal, I'll use a couple of the birth controls that are better options for each patient, because that's the other thing. It's so individualized care. That's why you need someone that knows what they're doing, versus like, a UTI. I have like Spectrum, Keflex, Macrobid, certain things I can put you on for 3 to 7 days and you'll get better. HRT and hormones are definitely like a game. But when you listen to the woman, it will guide you. Like, again, nothing is rocket science. So track your cycle, track your symptoms, come with your biggest complaint. I hate to say complaint because we're not complaining. We're just saying how we're feeling, and someone needs to listen to us. So it's not a complaint. Come with your biggest bothersome trait.
The thing that annoys you the fucking most and you need to be fixed yesterday.
Yes. And it's just wild. And you need someone that you feel comfortable telling things to, because you're going to talk about all the things, and in my sexual health side, I always care about libido, because not just libido. I care about sexual health, because sex is one of the few things in life that are free. It can be incredibly intimate, bonding. You need that. And that's a whole other podcast for like, what do we need first, and desire and responsive and spontaneous. There's no such thing as spontaneous, but we feel like there is. But we also don't live in a world that, I know, we need something that fosters a good sexual health and relationship with our partners. Nobody gives us time for that. Like, when are we supposed to do that? Between like potty training my 3-year-old, which thank God my daycare has done most of that. But between that and then getting my 1-year-old to sleep through the night and then working full time and then starting a business, and like, we don't have time for that, but we desperately need to. And until we move into a space that fosters that environment, we're going to be screwed. But there is some advances on the women's health side that can help with libido and drive, but it's almost never just one thing. It never is one thing.
Yeah.
It's a lot of things, but there may be things that your provider can help with if they know. I strongly feel very passionate about when I teach at the PA school or the NP school. I say to those clinicians, the next wave, I tell them vaginal estrogen, which by the way, today the FDA announced they will take off the black box warning label that comes with it that says vaginal estrogen causes stroke, breast cancer, which is so long overdue. Yeah. We need to stop fear-mongering women in this space. That's also a whole nother podcast of the misconceptions that came out of the Women's Health Initiative that got us to where we are today with hormones. But vaginal estrogen is localized. It can help with painful intercourse. If you have children and you decide to breastfeed, you most likely have experience vaginal dryness. It's because your hormones are depleted at that time. A little vaginal estrogen can help immensely, and there's nothing wrong with that, but nobody prepares us for that. So vaginal estrogen, I feel very strongly about women once they're menopausal, even before menopause, that they should have vaginal estrogen for the rest of their life. Apply it twice a week forever, because that will also decrease your risk of UTIs, which we know, and I saw first line in the ER, women in their 60s, 70s, 80s, 90s coming in with urosepsis, meaning they get sepsis, they get infection all over their body from a UTI. That's because with aging, you lose that estrogen. And when you lose that estrogen, you change the pH in the vagina, and the tissue literally atrophies and it becomes like a Kleenex. And then you hear some of the influencers say you lose your labia. Yes, things change and atrophy, and you then are more at risk to get a UTI because you're still going to the bathroom, you're still pooping, but anatomically everything kind of shifts and becomes very thin tissue, very susceptible to UTIs because our urethra is like this big. We can easily mitigate that by adding vaginal estrogen, keeping that tissue healthy. It's vaginal health. It's not sexual health. It's vaginal health that we should have for forever. I mean,
I have never heard the term vaginal health. That's kind of fucked up.
Yeah. Yeah. But we have a million erectile dysfunction meds, and I do men's health as well. And let me tell you, the minute that penis doesn't work,
right?
They come see me. Yeah. Dang. I mean, if they lost their freaking testicles or everything came shriveled up, oh my God, we would have a movement. Like, it's wild.
You are starting a movement. Like, you are part of a movement that is so needed. Again, my brain is buzzing. So could you touch a little bit on, and this is just coming from my chatter with women, and it's so frustrating. It's all very confused. I just want to say, one, you all know, if you listen regularly, you know that I tend towards the negative. Even my husband he's like, could you try and just see things through a positive lens today? Because we're trying on these lenses within our marriage and looking at things. He's like, I would like you to look for the positive. Like, I'm not wired that way. I see the negative and I'm like, this is what can be fixed to be better. So please excuse this me, like, this is bad and this is bad during this podcast. I do try to infuse a little bit of positivity. There is hope. That feels good. When I hear women talking about hormone replacement therapy, there's a lot of, you said fear. There's a lot of trepidation. There's a lot of, and I am still new enough to this space. Some of my friends are a good kind of 10 years older than me. So I'm hearing from this from them. It is not something that I have experienced, but the information that they have been given, they are, I don't want to say afraid, but they are afraid in a sense to go down this path. Can you kind of touch on that? Because you talked about the fear mongering and sort of outdated information and all of these things. Can you give us the sort of just baseline of information on hormone replacement therapy?
Yes. So this also, we could do a whole podcast on just this.
I know.
So back in circa the early 2000s, hormone replacement therapy really in the 1990s was a mainstream treatment for menopausal care. Through the years, they did discover, so it was estrogen, right? Estrogen, they saw all the benefits. They put women on it. They did learn that if you still have a uterus, so didn't have a hysterectomy, still have a uterus, if you give estrogen, you need to give a progestin because that will make it so you don't dump all this estrogen into the uterus and make it proliferate and overgrow and put the uterus at risk for building up the endometrium and causing hyperplasia or a risk for cancer. So we mitigate that by giving a progesterone, a progestin. I'm going to try to make this as simple as I can without overcomplicating it.
I know I'm asking a big ask in synthesizing it.
So what happened in the early 2000s was the Women's Health Initiative was started. And it was the largest study, randomized control trial with women of this type. So this is the gold standard of how we do testing and how we look at the effects on things. So they knew that hormone treatment helped with menopause. However, they weren't looking at that in the study. They were looking at how hormones affected everything else, cardiovascular health, stroke, cancer, etc. The trials were stopped early because they used a type of estrogen and a type of progesterone that they thought in one of the arms caused an increase in breast cancer. That actually isn't what they saw. And there was lots of flaws in the study, but the media ran with it. And there's a wonderful book that I've read twice called Estrogen Matters. And I think every woman should read that anyways. It's wonderful, but it really walks through what was wrong with the WHI, how the media got a hold of what they saw in the trial and then just blew it up. And I remember this because I was in high school and I just remember it being everywhere. Like estrogen causes cancer, study stopped early, And then from there, we've never been able to really recover until the last few years when there's been, menopause having this moment and there's been more people in this space and there's been people that break this down. And again, that's an oversimplification of what happened. And then providers were like, fuck no, like I am not going to prescribe anything that causes cancer. I mean, and I hear this every day. My primary care actually told a patient that is a mutual patient of ours that HRT causes breast cancer. And that's just not true. That is not true. HRT, hormone replacement therapy, when started within 10 years of your last period, or before the age of 60, started, not continued, but started, is for the majority of women a very safe and effective option for treating menopause. As you get further out, which is what we saw in the Women's Health Initiative, we saw that the further you were away from your last period and you had more risk factors, the more risky it became to add back in estrogen and or a progesterone. And there's lots of reasons why it is considered safer. We use another tip is anyone that says bioidentical hormones, that's just BS. The hormones that we use for menopausal treatment are as close to what our body makes as we can get. So we usually use estradiol for estrogen and then a micronized progesterone. And when we use those and we do it in a way that's individualized to each person, depending on their risk factors and all the things, it's relatively safe for the majority of women. There are exceptions. There are contraindications, no active breast cancer, no recent stroke or MI, no unexplained uterine bleeding. But even a family history of breast cancer does not rule you out, but you need a provider that knows. I mean, a lot of what I do is when I see women, they think that they can't take hormones, and I go through their history and I say, well, actually, these are your options. And then I will, whether I'm talking to the oncologist or their primary care or whoever, I will cite the study. I will attach the articles. I will say, this is the evidence. Like, please just stop fear mongering, because also taking hormones doesn't increase your risk of breast cancer any more than it would at baseline. It doesn't elevate the risk. Breast cancer is a real freaking thing. Like 1 in 8 women have breast cancer. There are patients that I've put on hormone replacement therapy that have gotten their mammogram. They've had a biopsy. It's a new cancer. Our hope is that you have a mammogram every year. We mitigate that. Heart disease remains the number 1 killer of women, not breast cancer. And there's no way in me saying this am I trying to downplay breast cancer, because that's not it. It's just that women shouldn't have to struggle in fear of one thing over another. I mean, we just shouldn't. So that's where all of that kind of gets mucked up. And, there's lots of things that we try to do now to mitigate the risk of stroke or clotting. We use a transdermal option. It bypasses the first pass through the liver. It can get absorbed. It decreases the risk of clotting. So people that have factor V can still use a transdermal option, and there's no risk compared. We don't want them to take an oral, but they can still use a transdermal. But a lot of providers don't know that or aren't educated about it. So it's hard to all cram in an hour when you're talking to these women, but it really is the fear that still is there. And I always tell people when I talk, look at COVID, look at the misinformation. With COVID, I was on the front lines with my physician colleagues who are intubating the people with COVID that didn't believe in COVID, that got COVID and then never came off the vent and died. Like, misinformation is deadly. And look, in the last 5 years, what it's done to this country. Now think about the Women's Health Initiative, 20 years of this fucking shit that we've been trying to recreate. And then I have physicians locally who are telling my patients HRT causes breast cancer. And that's hard because the hierarchy in medicine too, you go to your doctor looking for these things, but if they don't stay up to date, they aren't going to have adequate information. And again, they're doing the best they can. And I have a ton of family med physician colleagues and APP colleagues who I greatly respect. But if you are taking care of women, we make up half the fucking population. It's time to get up to date. It's time to stay up on these things, because not giving the information can be deadly, and quality of life matters. And hormones aren't a cure-all end all for everyone, but you should be given the information to make the best decision for you in your care and in your longevity, period. So I know it's fucking hard to learn another thing, but you need to do it. And I think as we age, and especially female providers, they go through it themselves. They'll have a different lens, like I did with infertility, that then just drives your passion. But it's something that I refuse to sit down and shut up and not talk about, because how can we not?
Yeah. Thank you. Having lived experience was it opens your eyes to what the fuck is happening. And this is not normal. This is not just, oh, you go through this. This is normal. This is fine. No, it's not. No, it's not. Okay. Can you just kind of tell us who it is that you work with? Give us sort of a synopsis of your patients, how you care for them and what they come in with, which we kind of already know, but what happens on the other side, and also ages of kind of the women that you work with.
Yeah. So I would say anyone, I have some 30-year-olds. I do some trying to get pregnant patients too, that maybe before they think they need to get to REI or reproductive endocrinology or things like that. And I happily refer when I need to. But a lot of times, PCOS patients or patients that maybe are having a tough time trying to conceive, I see a few of those. And then the majority is perimenopausal, usually mid to late 30s. And then all the way up, I have patients in their 70s who are like, don't take my hormones. And I'm like, nope, I won't. And then, we just do like a comprehensive, if I need to test, I'll test for labs. And then it's really just individualized care, but not rocket science. The perimenopausal space is really the tough chapter that's hardest to feel the best in, because your hormone levels are just all over the place. It's like a roller coaster, and they will continue to be like that until there's a total decline and you're at that last period. So I just tell my patients, like, give me grace. We got to be patient. We will get you feeling better. And then we kind of tackle it one hormone at a time and individualized care, really.
When you say, can you share a little, like the salt and pepper of it? One, I like that analogy. And then also when you sprinkle the salt and pepper, what happens?
Yeah. So, and I've learned this over time, because with experience, you learn the art of truly practicing medicine. And I saw this in the ER too. When I first started, I was like, oh my God, I've got to fix everything all at once, especially in the ER setting. Like, that's what I was wired for. And with perimenopause, especially, I have learned, because I would want to give them all the hormones all at once, because I was like, oh my God, I can make you feel so much better. Yep. From what you're telling me, it sounds like you need a little bit of progesterone, but you may only need that for half of your cycle. I'm not quite sure. Let's track. And then I'd be like, well, you're also having these hot flashes and this skin stuff, and you're having a lot of brain fog. I definitely think you need a little estrogen. And I would add it all at once. Now I usually take a little different approach. I first figure out, do they have a uterus or not? Do they have to worry about contraception? Is their partner, if they're partnering with a male, still, have they had a vasectomy or not? I have to play all those things into part. And then I usually pick one hormone to start with. And then the hardest thing for me is to give it time, because I'm a person of action.
I get that.
I'm like, oh God. And they'll be messaging me like 2 weeks in, oh, I don't feel any better. And I really have to like pull the reins and be like, okay, this is time. Remember your cycle, because the majority of perimenopausal women are still cycling. So your cycle is 28 to 35 days. That will change too as we go through this. But I just tell them, stay the course, track all your things, see how whatever hormone we first tried change things. And then we meet back, and then we usually say, okay, let's tack on something else, maybe a little estrogen. And then once we get the estrogen and progesterone kind of figured out, then that's usually when I add maybe a little bit of testosterone if they need it. And that's a whole other thing, because there's no FDA approved testosterone for women in the US. So that's always interesting. But you can compound it, or you can get it some other ways. But I kind of like that approach versus everything all at once, because perimenopause is not the same treatment as menopausal hormone care. And it seems easy, but it's really an art. So I usually say, like, just patience and communication, and track the shit out of all the things. And then let your provider know what has worked in the past and what hasn't worked. There's all sorts of things, like when I do a history, I want to know if they've been pregnant, like how they did during pregnancy, what their symptoms were, because at pregnancy, you're hijacked with estrogen all over the place, and there is a correlation. So the more information you can provide your provider, the better.
Yeah, I like that. And I really love it. It seems very intuitive, because you're listening to the woman in front of you, and let's try this. And I actually think, just from the women that I know, I feel like we are a very patient bunch, because we've been dealing with a lot of this for so long. So it's like, yeah, let's just ride this wave and see what we can get. But I can see from your perspective how that would be like, all right, when you're especially fresh into it, like, let's go. Buckle up. We're going to make you feel better tomorrow.
Yeah. And when people have come to me, because a lot of times people get to me in my full-time job, I care for employees at institutions. So I can see the employees, their spouses, their dependents. But out in the wild, by the time women get to me, they've been to maybe some other entities in town. They've been to their primary care, their gyne, and they've already done all these things. So they are like, oh my God, I need you to fix this now. And it is hard because it is not overly difficult, but it requires patience and grace. And sometimes I have no two women that are on the same regimen. Like everyone's just a little bit different. It's individualized care, but having a provider that knows what the hell they're doing is what you need. There's a lot of plug and play. There's a lot of aesthetics businesses doing this that aren't educated. They think it's easy. There's a lot of online stuff. People can get this, but again, women are desperate because no one will listen to them. So there has to be a space for women to go, and providers need to be doing this because it isn't rocket science. It's just a skill that takes some time to acquire and figure out, and we deserve it.
We absolutely deserve it. Every one of you listening deserves to feel your very best, all of the fucking time. All right. Are you taking new patients?
Yes.
Okay. How do people, was there more with that?
There's a little bit of shift that's going to happen after the new year. And my hope, and when I started on this journey, I wanted to see all of the women. I wanted to take care of everyone. That was my fix, but there's one of me. So I'm kind of moving towards something that I still will consult with women and coach them through what they should do. But I'm really kind of moving towards giving them all their options. And then they take that to their primary care, their OB-GYN, because that will also, number one, I don't want to make money off of this. I don't want women to have to pay a private fee to come see me. That's fucked up.
That's really hard. That's a tricky thing with this is they tell me how much it is, and I know how much I invest, and it's not everybody has access to that.
Yes. And that is what I preach. That's the only reason why I won't keep doing one-on-one consulting and prescribing is because it should be something that's free and available to all. And I hope that will then drive the institutions, the health systems to then invest and use their administrative money to hire people like me to train their providers, because I know not all providers can take all the training like I did and do all of that. I know that's a big task, but also it is time. Women deserve this. This is what needs to happen. So I'm hopeful that will shift things, but I don't want to take that away from women either. So I still will coach them, meet with them, give them all the options, and then be this is your next step. But I also want to empower women to be this is how we do it. Have this stuff laid out. This is how you talk to your provider. And if they say no, you find a new one. But I know how hard that is because in the state of Wisconsin, there's a website where you can find menopause trained providers, and there's not a lot of us. But
yeah,
I'm hoping it will get the ball in motion.
Yeah. Okay. And that website was what is that one again?
That's the Menopause Society. Find a provider. Yep.
Okay. We'll post that. I'll share that in the show notes so that you all have access to that. And then how can people kind of get into your your community of love and let's fucking change this shit and soak up all of your knowledge? How do we get more of you?
Oh, so great. So I'm not a social media person, but I'm trying to become one.
You are doing a damn good job for not being a social media. Because I think we connected when you had one post, and you are doing really well.
Oh my gosh, you're so kind. I never know what I'm doing. I read the posts 520 times before I hit upload or whatever it is. But I'm on Instagram, Midlife Rising, and also LinkedIn. And then I have a website, which I am so incredibly proud of. These women, and this is just another example, and I have to give them a shout out. I partnered with a local photographer who was incredible, and I told her my vision, and I said, this is what I want this to look like. And we used real women who showed up for me, posed halfway naked. And that is my beautiful website. And I'm so proud. So that's midliferising.org. And you can reach me on there. There's a little link that you can, it'll say book to speak. That's like for corporations, but I mean, anybody can do that. You don't have to.
You have a lot of resources on there too. I was like perusing around, and yeah, your photographs on there, beautiful. You can, like I said in the beginning, your energy, like it oozes out of you. You have the sparkliness that like your glitter just like transfers to people, and everybody gets to like soak you up. All right. Thank you so much, Miranda. Like you said, I think so many times that could be another podcast. Like you are a wealth of knowledge, and I'm so thankful for what you are giving to future providers and women and empowering them, and the mission that you are on, because we need it. We need you. The world needs you. Women need you. And you are just out there showing up and doing the hard shit that also is it has to be so rewarding, because we all just need your information. So thank you so much. And all of the resources that you shared will be in the show notes. So you don't have to worry about that. Just go and click on them and you can find more on Miranda.
Thank you for having me.
All right. We'll see you later. Spirit of a Badass is a Lit Path Studios podcast and is produced by Jamie Gale and Alecia Jacobson. Music by Shane Ivers. We'll be back with another inspiring interview. Until then, keep your spirits high and your energy badass.